Hi, this is Dr. Stephen Liu. I'm a medical oncologist and the director of thoracic oncology at Georgetown University in Washington, D.C. And today we'll talk a bit about small cell lung cancer. These are my disclosures. Small cell lung cancer is a less common, but not a rare subtype of lung cancer. It is strongly linked with smoking, though not all cases occur in smokers. Due to its relationship with smoking, the incidence of small cell lung cancer will vary based on the part of the country or the part of the world that you're in. The incidence of small cell lung cancer in the US is going down. It peaked in the early 1990s at about 25%. Now it's about 13% of new diagnoses in the US, but again, very significantly based on the part of the country. We've seen a shift in demographics. In the 1970s, this was mostly a cancer of men, whereas now it is about 50-50. This is a cancer that occurs generally pretty centrally, and so we'll see descriptions of a large hilar mass and large lymph nodes in the center of the chest. Common symptoms would be cough and shortness of breath, hemoptysis, or coughing up blood. Typically, those will occur in the course of a few months. Systemic symptoms like weight loss, decreased appetite, fatigue, bone pain are very common. Paraneoplastic syndromes are conditions related to small cell lung cancer. These may be lab abnormalities or neurologic conditions, weakening muscle conditions, vision conditions. These are related to the body's interaction with its very unique type of lung cancer. Under the microscope, there's a very characteristic appearance. You'll see terms like neuroendocrine differentiation. This is a neuroendocrine tumor. Older terminology would be oat cell morphology, and oat cell cancer is the same as small cell cancer. Of note, sometimes you will see a mix of small cell and non-small cell. And when that occurs, we treat based on the small cell component. More recently, in the era of targeted therapy, we have seen certain subtypes of non-small cell lung cancer transition to small cell lung cancer. For example, an EGFR mutant non-small cell lung cancer may start as an adenocarcinoma, but after targeted therapy, it may change into a small cell lung cancer, and that transformation is the mechanism of resistance. Very rarely that occurs at the beginning, and this can also occur in other targeted subsets, such as ALK and RET lung cancers. This can only be diagnosed by biopsy. A liquid biopsy or a blood-based test would not identify these. We stage small cell lung cancer formally by the same TNM staging system, but in clinic, we rely on the modified VA lung group staging system, which splits small cell into two stages: an early limited stage or a later extensive stage small cell lung cancer. Limited stage is a cancer confined to one lung and lymph nodes that can be covered by one radiation port. Anything distant or spread outside a radiation port would make that extensive stage small cell lung cancer. And unfortunately, most cases are extensive at the time of diagnosis. Our goal here when we're staging small cell lung cancer is to identify the presence of distant disease so that we can eliminate radiation if it's not going to be of benefit. That typically would include a CT scan that would include the chest and the liver and adrenals at least, an MRI of the brain with and without contrast when possible, a bone scan, or preferably a PET scan. And if there are effusions or fluid collections, we may need to biopsy those to see if they're related to the cancer. We want to do staging to guide therapy, but doing all these tests doesn't necessarily need to hold up the initial treatment. For limited stage small cell lung cancer, our goal is cure, and we can achieve that with a combination of chemotherapy and radiation. For extensive stage small cell lung cancer, unfortunately, cure is not what we expect with standard therapy, but treatment is still of significant benefit, improving the quality and quantity of life. But our mainstay of treatment has been chemotherapy.